So hello everyone, welcome back to my channel MedPath with Piyush, and today we are going to start a very important family of bacteria, that is Enterobacteriaceae. The first bacteria we are going to start with is Shigella. It's a very important family as far as your exams are concerned, be it MBBS exams, be it any NEET PG, AIIMS or USMLE. So let's start firstly with introduction to the Enterobacteriaceae family. So the family consists of gram-negative rods. That means they are, when you do a gram stain, there will be pinkish bacilli that you will see on a gram stain. Okay. Next up, they are facultative anaerobes. This is one of the important points to know about these organisms, that they are facultative anaerobes, and all of them uh, are motile by peritracheous flagella, except, so these exceptions that you need to know are Klebsiella, Shigella, Yersinia, and atypical E. coli. These four are not motile, otherwise all are motile. So today we are studying Shigella, so that means it is non-motile. Okay, some general biochemical reactions to know about for all the Enterobacteriaceae family members is that they're all catalase positive and they're all oxidase negative. Okay, and all show nitrate reduction test positive. That is, all will convert nitrates into nitrate, and they all are non-fastidious. That means they can be grown on simple media as well. Okay, they can be grown on simple media, and gram stain can be done further for them. Selective media that is used for them is McConkey agar, which actually consists of plant. P for peptone, L for lactose, that makes it differentiating media. A for agar, N for neutral red, and T for taurocolate. This will show two types of colonies: pink colored colonies if the bacteria are lactose fermenting, and pale or yellow colored colonies if they are non-lactose fermenting. Okay, so next, moving further, we have introduction to Shigella, specifically Shigella, not Enterobacteriaceae in whole. It is a gram-negative rod, and it is non-MSC. You remember my mnemonic, Master of Science, that is for motile, sporing, and capsulated, and it is non-MSC. So it's non-motile, non-sporing, and non-capsulated. It's a facultative anaerobe, and colonies of on McConkey agar are pale yellowish. As I've already explained, what does pale yellowish intend to show here? That is non-lactose fermenting colonies. But there is an exception, that is Shigella sonai. Sonai means सोना. तो सोना मतलब सो के लेट उठ रहा है, ठीक है. So they are late lactose fermenter. They are late lactose fermenter, except for other species which are non-lactose fermenting. You should know the next all the three mediums, as they're important for your laboratory diagnosis as well. So transport medium is Sachs buffered glycerol saline and Carey Blair medium. The one you need to remember is Sachs buffered glycerol saline, as it is very important. Enrichment medium, one important one you have to remember is selenite F broth. That is enrichment medium. And Salmonella Shigella agar. Selective media, there are three: DCA, XLD, and hectoin enteric agar. DCA means dextrose, deoxycholate citrate agar. XLD means xylose lysine deoxycholate agar, and hectoin enteric agar. Okay, so that was introduction to Shigella. There is classification of Shigella done on the basis of O antigen. O is a somatic antigen, that is also a minor antigen. Shigella has antigenicity on the basis of many major and minor antigens. There are major antigens and there are minor antigens. In minor antigens, there are O antigen, that is somatic antigen. There is flagellar antigen, and there is K or capsular antigen. Okay. Then there are four subgroups that are named as A, B, C, and D. Subgroup A refers to most important, the Shigella dysenteriae. The subgroup B is Shigella flexneri. It is most commonly found in India. Then subgroup C is Shigella boydii, and D is Shigella sonai. the characteristic feature of which is late lactose fermenting colonies. These all are non-lactose fermenting. Okay, so remember this classification. Next up, we are coming to biochemical reactions. In indole tests, they all are variable. Okay, methyl red test is positive by them. Nitrate reduction test is positive as they are member of Enterobacteriaceae. Enterobacteriaceae. They do ferment glucose, so they are K by A with gas negative. They do produce acid, but they do not produce gas, so you should remember that they are gas negative. This is an important point. No H2S or any gas produced. They are catalase test positive and oxidase test negative as they are members of Enterobacteriaceae, and citrate utilization test is negative, so they will be showing green color here. And mannitol fermentation is done by all the subgroups except subgroup A, the most important one, that is Shigella dysenteriae, that does not show mannitol fermentation. Next up, we come to Shiga toxin. Shiga toxin is one of pathogenic why Shigella is pathogenic, that is due to Shiga toxin. So Shigella dysenteriae type 1 that produces Shiga toxin. The only member to produce Shiga toxin is Shigella dysenteriae type 1. Okay, that produces Shiga toxin. That is why Shigella dysenteriae type 1 is known as Shiga's bacillus. Okay, the other name for Shiga toxin is virotoxin, and this is similar to EHEC. What is EHEC? Enterohemorrhagic E. coli. We are going to study about E. coli in the next video, so please be ready for that and do comment if there is any specific video that you will want. Okay, and this Shiga toxin is neurotoxic, enterotoxic as well as cytotoxic because of its toxigenic nature. It consists of two subunits, subunits A and subunit B, and B is generally for binding and A is generally the active unit. Okay, the toxin is arranged in this form. These are B subunits. There are 5 B subunits, and in between there is A subunit. And A is further of A1 and A2, out of which A1 acts on 60S ribosomes and inactivates 60S ribosome and thus inhibits protein synthesis. Also important point to learn about this is that Shiga toxin is also an exotoxin. It's not an endotoxin but an exotoxin. So it's proteinaceous. We are going to study about some proteins in the next slide as well. Okay, so pathogenesis, this causes bacillary dysentery or shigellosis. Okay, bacillary dysentery is generally a term used for much more severe cases and shigellosis for normal cases. It has a low infectivity dose of just 10 to 100 bacilli. That means a very low, even 10 to 100 bacilli are enough to cause the disease in a person. Okay, because they can survive gastric acidity. This is very important point. They can survive two of the most important things in GIT, that is gastric acidity as well as bile salts. Okay, they have invasive property which is makes them similar to EAEC, that is entero-invasive E. coli. As I've already told, we are going to study about all the E. coli in our next video. Okay, and their invasive property is due to some proteins, and that protein is known as virulence marker antigen VMA. It is important to know about this, and it is also present in EIEC, and they are also named as EPA proteins. Okay, so exotoxin pathogenesis due to exotoxin name as the Shiga toxin, which is only produced by Shigella dysentery type 1, and endotoxin, that is in the LPS layer of all the gram negative bacilli, and it is a gram negative bacilli, so it has LPS layer, so ultimately it has endotoxin. Okay, next moving to how pathogenesis occurs. There is ingestion of Shigella. They are resistant to bile salts, resistant to acidic pH. Okay, so they enter the M cells. Please remember these. They infect the M cells. There is transcytosis by M cells. Okay, there is pinocytosis, and ultimately they move to the basolateral membrane. At the basolateral membrane, they are phagocytosed by macrophages. Okay, Shigella is phagocytosed by macrophages. Then there is pyroptosis. There is destruction of macrophage, and the Shigella comes out, and then they go inside the uh, other cells, epithelial cells. So there is invasion of epithelial cells by actin polymerization, by actin polymerization, and then there is transcellular spread, cell to cell spread that occurs, and due to this there is coagulation, there is necrosis, and then there is neutrophilic infiltrate, there is recruitment of neutrophils, and that causes dysentery. So this is the pathogenesis that you need to make in your exams. Okay, so what is bacillary dysentery? You need to know about its features. There is acute onset. Okay, clinical features induce loose and scanty feces that contain blood and mucus. That is, the feature that makes it dysentery, that the presence of blood and mucus. Along with, there are abdominal cramps and tenesmus. If you don't know what tenesmus is, you should know that tenesmus is actually the feeling to pass out the stools, but when you actually go to pass out, uh, no stools come. So that is just, a feeling that you have to constantly, defecate, but when you go to defecate, there is no defecation. Okay, complications can induce arthritis, toxopneuritis, conjunctivitis, peritonitis, but the main one that you should remember and write in your exam is intussusception. That is especially seen in children, especially seen in children. One important complication is HUS. HUS, the full form is hemolytic uremic syndrome. That is due to, invasion of the glomerular capillaries. Okay, the kidneys. Okay, and it presents with a characteristic triad of acute renal failure, microangiopathic hemolytic anemia, and thrombocytopenia. So this triad you should absolutely know about. Okay, important triad. Okay, one important thing that you should know about is a question that comes very much in your theory exam, that is bacillary versus amoebic dysentery. So actually we will study it more in depth in, when we do amoeba, but just to give you some of idea, I'll discuss it with you. Okay, so generally the bacillary dysentery is acute in onset, that we have already discussed, while amoebic dysentery is insidious in onset. Fever and toxemia are generally commonly present in bacillary dysentery, while they are uncommon in amoebic dysentery. The number of stools, there are many in 24 hours. Tenesmus is there. Okay, severe tenesmus is usual. Tenesmus is rare in this case. The number of stools are many in 24 hours. Intestinal colic is severe. Very colicky, severe pain is there. Here, intestinal colic is present, but it's not too much of severe. There is scanty, bright red and viscid pink colored mucus is present, while hair stools are copious, they are not scanty, they are copious amounts. Okay, and stools are offensive in case of amoebic dysentery, while they are odorless. This is a very important point. Odorless stools in the case of bacillary dysentery. Okay, so this you should know by heart. So as you have to write it in your university exams. Okay, in epidemiology there is incubation period of 12 hours to 5 days generally, and the mode of infection by which the spread is many. They can be direct spread by fingers, fomites. There can be contaminated food and water, flies, and also in homosexuals they can spread by gay bowel syndrome in homosexuals. We have already discussed they have a low infectivity dose of just 10 to 100 bacilli. Okay, next up, we come to important part of every organism that we have to do, that is laboratory diagnosis. The sample that you have to take is fresh stool sample or rectal swab, while rectal swab is generally unsatisfactory. So generally fresh stool sample is taken. Transport medium we have already discussed, sacs, buffered glycerol saline, Carrie Blair medium, and one more, that is gram negative broth. Then you can do microscopy on it. On gram stain you'll get gram negative rods or bacilli. In culture media, there is enrichment medium, that is selenite F broth or Salmonella Shigella agar, as we have already discussed. Selective media, DCA, XLD, and heptine enteric agar. Once again, I'll repeat: DCA is deoxycholate citrate agar, XLD is xylose lysine deoxycholate agar, and heptine enteric agar. Serology is not useful in this case. PCR can be used for rapid diagnosis, and ELISA is used to detect proteins. VMA detection in stools. What was VMA? Do you remember? Virulence marker antigen. What is the other name of this? EPA proteins. Okay, so it's important to know about this, as it will also come when we study enteroinvasive E. coli. Okay, next moving to treatment. Generally it's a very self-limiting condition. No much of treatment is required. Supportive management is done, and oral rehydration therapy is done due to dehydration. Okay, if there is severe infection, then antibiotics can be used, and antibiotic that is much most likely used is fluoroquinolones. Example is ciprofloxacin. Okay, it is ciprofloxacin. Okay, no effective vaccine is available for this. One important point that is a contraindication to treatment of shigellosis is do not use antidiarrheal or anti-motility drugs. Do not use antidiarrheal or anti-motility drugs, because in that case what they will do is that they will try to make the person constipated or decrease the motility. In that case it will actually worsen the symptoms by decreasing the clearance of bacteria. If you will stop the diarrhea, so bacteria will remain in the gut, and ultimately the person will have decreased clearance of bacteria. There will be risk of toxic megacolon and severe infection. So guys, that was it for Shigella. I hope you liked the video. If you like the video, please give a thumbs up, comment down if you need anything. You can get these notes by just going to my Instagram, that is Math Path with Piyush. And for further content, please subscribe the channel, press on the bell icon, and remain with me. Thank you.